All, my name is Paget. I'm the leader of the nephrologists at this hospital. You know, these Friday morning meetings are always a little bit like your child's 5th birthday party. You're not sure if he's got any friends, and you know, you set out all your things, and then 10 o'clock's coming and you're hoping some people will pitch up, otherwise the poor little guy will be heartbroken. So thank you very much for coming to our party. We appreciate it. It gives me great pleasure to introduce Dr. Mokoka. She's one of our younger consultants. We are all very young, as you can see. She will be talking to us about an important topic. We know that salt is evil and is vilified, but funny enough, if you don't have any, that's also a problem. So over to you, Ledile. Thank you.
Thank you, everyone. Thank you, Prof. Without wasting any further time, let's get on with it. So basically, our talk today will be a nephrology perspective on hyponatraemia. There, right? Yeah. Okay, this is basically the outline of our talk. We'll do a bit of physiology, how the kidney handles sodium, the hyponatraemia, syndrome of inappropriate ADA secretion, and the clinical manifestations of hyponatraemia. So basically, sodium is the most important extracellular cation with normal values ranging between 135 and 145. Intracellularly, the normal values ranges between 10 and 12, and it's responsible basically for 90% of the total osmolality of the extracellular fluid. And maintaining this transmembrane concentration gradient is very important for generating membrane potential and action potential propagation. And sodium is therefore important in regulating intravascular volume and is highly linked to fluid balance and blood pressure control. Okay, so how does the kidney deal with the sodium? Sodium is freely filtered through the glomerulus of the kidney, but 65% of it is actually reabsorbed back by the proximal tubule. It does this by the concentration gradient, which is created by the sodium-potassium ATPase on the basolateral side. And the most of this is actually reabsorbed using the sodium-hydrogen exchanger co-exchanger. And then some of it is via the SGLT2 transporters or co-transporter with the sodium phosphate sodium phosphate T2 and other multiple organic anion co-transporters. Of note, none of it is actually reabsorbed on the thin descending loop part of the loop of the nephron, and very little of it is absorbed on the thin ascending part and is passively. 25% of it is reabsorbed on the thick ascending part of the loop of Henle, and that is via the furosemide sensitive sodium potassium 2-chloride co-transporters, and only 5 to 10% of it is reabsorbed distally via the thiazide sensitive sodium chloride co-transporters. And often note that at this step actually is load dependent. If there's more sodium that reaches this part of the nephron, actually more of it will be reabsorbed, and only about 2% of it is reabsorbed at the collecting duct by amiloride sensitive innate channels. So this is just a summary of just what I've just explained. I will pass that. So this reabsorption needs to have some form of a regulation. So there are 4 hormones that are involved in the regulation of the sodium reabsorption by the kidney. So angiotensin 2, it increases the reabsorption by increasing the sodium potassium ATPase activity proximally, and also increasing the activity of the sodium hydrogen exchanger. Aldosterone increases innate channel at the collecting duct, and also sodium potassium ATPase activity in the thick ascending limb, while vasopressin increases expression of the index in the collecting duct and the sodium potassium chloride 2 in the thick ascending limb. Catecholamines also plays a role by increasing sodium potassium 2 chloride expression in the thick ascending limb. So I'm going to summarize those busy slides in few sentences. Basically, the renal sympathetic nerve activity also plays a role. In the presence of hypotension, that will be detected by the baroreceptors that are found on the carotid or the arc of the aorta, and or with hypovolemia that will be detected by the reduced distension of the atrial myocytes that will stimulate the sympathetic nervous system. One of the many effects of this renal sympathetic nerve activity is to increase sodium reabsorption in the PCT by activating alpha-1 and alpha-2 adenoreceptors. And as a result, this is going to promote fluid retention and thereby increase the intravascular volume and blood pressure. Another system that we all know that is important as far as the kidney is concerned is the rest system. So reduced renal perfusion or reduced sodium delivery to the distal part of the nephron is going to be sensed by the granular cells that are secreted by the just glomerular apparatus, and that will result in increased production of the renin that leads to the production of angiotensin II. And we've already discussed that angiotensin II increases the activity of the sodium potassium ATPase and also the activity of the sodium potassium chloride exchanger, and as well as the sodium hydrogen exchanger proximally. So the rest of the system has numerous effects which work synergistically to increase the blood pressure, particularly petition to sodium balance in increased sodium reabsorption in the nephron. So the ANP and the BNP, so when raised blood volume causes an increase in venous return, this is going to be sensed by the stretched atrial myocytes, and they will stimulate the production or the release of ANP, which is atrial natriuretic peptide and brain natriuretic peptide. So these hormones actually, they promote natriuresis, meaning urinary loss of sodium, to reduce the circulating blood volume. So ANP and BNP act to actually reduce aldosterone secretion and renin secretion. Therefore, they counterbalance the actions of the other two hormones. Another hormone that we cannot deal with sodium without entertaining it is antidiuretic hormone, ADH. This increased plasma osmolarity, for example, during dehydration, is going to be sensed by the osmoreceptors that are found in the hypothalamus. And that is going to stimulate the production or the release of ADH from the posterior pituitary gland, and a significant reduction of an effective circulatory volume, at least about 12 to 15%, need to be there to be sensed by the baroreceptors to stimulate the secretion of ADH. And we do know the action of ADH is actually to increase the expression of the aquaporin 2 via their V2 receptors at the collecting duct and making them more water permeable, thereby promoting water reabsorption. So let's go to the meat of the presentation. So it is defined as a sodium less than 135 millimole per liter. And of note is known that at least 50 to 25% of patients that are hospitalized, they will have hyponatremia. Sadly, it's associated with increased morbidity and mortality, and older people are particularly at risk of having hyponatremia. And hyponatremia is clinically significant when it affects the plasma osmolarity. Just to remind you, the way you calculate the plasma osmolarity to be 2 sodium plus the urea plus glucose, and your normal should rank between 280 to 290. So what will be your diagnostic approach when you are confronted with a patient with hyponatremia? So you must first actually assess their volume status. Are they hypovolemic, euvolemic, or hypervolemic? If they're hypovolemic, then you need to measure the urine sodium so that you can deduce, is this a sodium loss from the kidney or an extrarenal loss? So if it's so you measure your urine sodium and it's above 20, then you need to entertain the possibility that the loss might be coming from a renal source. Either it's a diuretic excess or mineral corticoid deficiency or a salt-losing enteropathy. But nephropathy, I should say. If it's your urine sodium is less than 20, the patient is hypovolemic, then you need to entertain extrarenal causes, typically your gastrointestinal losses. Is it vomiting or diarrhea or spatial fluid loss, such in cases of pancreatitis or Benz? So if the patient is hyponatremic and they're euvolemic, then you need to entertain, is it the glucocorticoid deficiency, or is it hypothyroidism, or is it syndrome of inappropriate antidiuretic hormone release? The hypervolemic part is quite easy. You measure the urine sodium. If it's greater than 20, is it an acute or chronic renal dysfunction or failure or injury? Or if it's less than 20, you need to entertain, is this from cirrhosis? Is this from cardiac failure? Or is this from nephrotic syndrome? So syndrome of inappropriate ADH is a disorder characterized by impaired water excretion caused by an inability to suppress this hormone. So because it's inappropriate being secreted despite normal or increased plasma volume, then results in impaired water excretion and subsequently hyponatremia and hypoosmolality. So ADH, which is the main hormone that is involved in SIDH, it acts via two receptors. You've got your V1 receptor, the A and the B, and the V2 receptors. In essence, the V1A receptor is actually responsible for vasoconstriction, while the V1B is responsible for ACTH secretion. And the V2 is the one that acts actually on the collecting ducts and promote water channel acquiring 2 in the luminal surface, luminal side of the membrane of the collecting duct, therefore making them more water permeable and for more water reabsorption. Basic physiology. Normally, when the plasma osmolality falls below 275, vasopressin secretion stops. Then that will result in increased water excretion, which will lead to a more dilute urine. However, when plasma osmolality rises, at least by 8 to 10%, there need to be reduction in the circulating volume of the vasopressin. So the diagnostic criteria, very, very important. SIDH is a diagnosis by exclusion. You need to have entertained other things and made sure and satisfied yourself that there isn't any hypothyroidism, there isn't any glucocorticoid deficiency, the plasma osmolality needs to be at least less than 270, and there need to be an inappropriate urinary concentration of at least above 100, and the patient needs to be euvolemic, and you need to have an elevated urinary sodium of at least above 40. And the others are just supplementally part of the criteria, such as abnormal water load test or the plasma vasopressin level that will be inappropriately elevated. So it shouldn't, in most of the cases, be your first to go diagnosis. You need to have satisfied this prior to you coming up with the diagnosis of an SIDH. There are many causes to SIDH, but often not just to mention the important ones. It can present as a paraneoplastic manifestation in neoplastic processes, especially in the lung cancers, especially small cell carcinoma. Pulmonary infections such as tuberculosis, abscess, and aspergillosis can be associated with it. Central nervous system infections such as meningitis and bleeds. Drugs, which are AVP analogs, or the ones that stimulate AVP action. The analogs would be your demospressin, oxytocin, and vasopressin, and the anti-epileptics, the SSRIs, and the NSAIDs can actually augment the action of ADH and others as well. So how does the brain deal with this, with hyponatremia? An adult brain is encased in a rigid structure that limits its ability to expand. So brain cells are nature beautiful. Brain cells, they have developed a mechanism to prevent the cell volume increase. And those things are called the mechanisms of regulatory volume decrease, as they counter-regulate the increase in cell volume imposed by hypoosmolarity. So however, this is time dependent. So the first thing that would happen during the process of hyponatremia is that there would first be a release of intracellular potassium and fluoride, which will then decrease the intracellular ionic content and induce an osmotic shift of the water from the inside of the cell to outside of the cell. However, this can only compensate for a maximum of about three hours. If hyponatremia persists beyond that time, then there's going to be an extrusion of the non-ionic osmotically active substances from the inside of the cell, such as taurine, which are important in order to counterbalance the effects of hyponatremia. This is just a schematic representation of what I was talking about. So if you check on A, under normotremia situation, so there's a balance there, the intracellular and the extracellular, meaning that the potential is still maintained because you have more of the sodium extracellularly compared to intracellularly. Then you have acute hyponatremia, which is described as hyponatremia that developed less than 48 hours. So the brain has to compensate for that. And it does that by then releasing potassium and other of the osmotically active ions out of the cell into outside the cell. And we know that water is going to follow that, right? But that can only do it for some time. So when you get to a state of a chronic hyponatremia beyond 48 hours, now you're going to also lose the non-ionic osmotic substances, and water is going to follow up that. So osmotic demyelination, I'll entertain it because it's actually a complication of treatment. So the special slides on that. So who are people at risk of developing neurological complications of hyponatremia? post-operative menstruating females, elderly women taking thiazides, children, and of course, hypoxic patients and marathon runners. And like I said, osmotic demyelination syndrome, I will talk about it as we go on. Just now, we'll actually be dealing with it. So osmotic demyelination actually occurs as a result of rapid correction of chronic hyponatremia, mostly affects the central pons. So it used to be thought that it's exclusively affecting the pons, but we now know that even though the predilection is towards the pons, but other parts of the brain actually get to be involved. And the symptoms that are related to it, they tend to present in a biphasic manner, meaning that the patient initially has what looks like encephalopathy-associated rapid correction of hyponatremia, and few days later, they start having behavioral changes, they start having cranial nerve pulses, they can progress to weakness, tetraplegia, and some they may have a locked-in syndrome. And the best mode of modality to actually investigate and maybe prove the osmotic demyelinations and MRI, which would show non-enhancing hypertense pontine lesions commonly. And however, one should be aware that actually an MRI might be normal in the first 2 weeks and with no changes. It doesn't mean if your MRI with those symptoms is normal, you can exclude it. So the pathophysiology is quite unclear, but then this is a hypothesis, is that there's a sodium channels T2 that are downregulated by hypotonicity. And then the hypothesis also says that although the serum sodium and potassium return to normal when you correct the hyponatremia, the non-active or the non-ionic osmotically active substances that tend to come out of the cell into the extracellular space later on, they tend to return back even later. So that requires several days. The temporary imbalance during that phase causes the cerebral dehydration and can lead to breakdown of the blood-brain barrier. And of note is that the astrocytes and oligodendrocytes are actually the cells that are quite vulnerable during that phase. And evidence now suggests that it's no longer uniformly fatal. In the past, we used to think that once you have osmotic demyelination syndrome, then it's fatal. But now people tend to find out that some patients, not all, obviously don't want patients to have an ODS, but in some patients, they do recover with time, some they obviously don't. So it's no longer being associated as it being a fatal complication. But nonetheless, we should try our best to avoid it. So I think I've spoken about how patients can present, and I've emphasized that it's not only affecting the pons, the cerebellum, the thalamus, the putamen can also be affected as well. So this is an MRI of the patient. Not sure if the arrows actually project quite well on the right-hand side, that it shows the non-enhancing hypotense lesions. And then if you see on the left, it can actually be that it might be normal. And when you do it after 2 weeks, the patient might actually have this. And you would consider it if after 2 weeks of correcting and you think overshot during the correction of hyponatremia, and the patient starts to have a sequelae of neurological symptoms. So cerebral edema, the development of cerebral edema depends on the cerebral adaptation to hypotonicity. So decrease in extracellular osmolarity results in the movement of water into the cell, increasing intracellular volume and causing tissue edema. So aquaporin 4 is actually the key, play a key role in the movement of water across the blood-brain barrier. And cellular edema within this confined cranium actually would cause an increase in intracranial pressure. So this would be the effects of chronic hyponatremia. And some of them, they might remain subtle. Some of them, we might not even associate with them because patients are going to present later. For example, neurological symptoms, I suppose you can think about them because it's what we are taught most. But we don't actually get to be taught that there might actually be cardiac complications of chronic hyponatremia, right? Such as interstitial and perivascular collagen deposits, decrease resulting in loss of cardiac myocytes number and eventually resulting in cardiac fibrosis, such as stimulation of the osteoclastic osteogenesis and increased osteoclastic resorption, such as reduced vitamin D levels and increase the risk of osteoporosis later in life and increased risk of fall and skeletal sarcopenia. So those are the things that we need to think about. So how do we deal with this? So treatment and duration of hyponatremia actually is determine the treatment, and acute hyponatremia patients are at risk of cerebral edema, as I've mentioned. Chronic hyponatremic patients are at risk of osmotic demyelination if hyponatremia is corrected too quickly. Hope that it's projecting well. So treatment of patients with symptomatic hyponatremia. If it's acute, meaning less than 48, you might need to emergency correct that, provided you're going to monitor your patient. You can use hypertonic saline, 3% at 1 to 2 ml per kg per hour. And you can co-administer that with furosemide, but please monitor the patient to make sure that you do not overshoot and go above 8 millimole in 24 hours. If it's chronic, meaning it's above 48 hours, some immediate correction may be needed. You might consider hypertonic saline, the same doses, especially if the patient is symptomatic, they're having seizures. You can co-administer it with furosemide, but I cannot emphasize it more and more that you need to monitor your patient to make sure that you don't go beyond that which is acceptable. And then if they're asymptomatic, rarely is less than 48 hours, and most of the time, actually, there isn't much of indication for immediately wanting to correct it. And then long-term management, you need to identify the reversible causes. Is the patient on diuretic? What contributed to this? Is there a need for water restriction? Urea, 50 to 60 grams, it can be considered. And also, do you want to use V2 receptor antagonist? So those are the things that you can think about. But the emphasis, if I were to emphasize even further, is that do not overshoot, do not overcorrect hyponatremia unnecessarily. So then how do we deal with severe acute and chronic hyponatremia in hemodialysis patients? Typically in patients that would have indications for acute dialysis, let's say, for example, they have a refractory hyperkalemia and you are calling for nephroconsult and we need to consider dialysis in this patient. Obviously, due to the fact that I've mentioned that if the sodium is like 116, then we are running at risk of having complications. So we need to know in nephrology as to how best can we dialyze your patient. If you're pestering us into you need dialysis in ICU and your patient is hyponatremic. So we're going to say if there's severe acute hyponatremia, let's say it's less than 120. So we can use a 3% saline bolus, at least at 150 ml for severe symptoms. And then if you're going to do rapid correcting using an intermittent hemodialysis, at least your hemodialysis, your dialysator should at least have a minimum of about 130 millimole of sodium in the solution. However, the vasopressin receptor antagonists are not necessarily recommended. If it's a severe chronic hyponatremia, you can still do the above. However, if it's chronic and your sodium is less than 120, it's actually better to do daily short interval with the lowest speed possible, meaning your speed pump should run between 50 and 100. And then if you do not have access to consumables of CVHD, which is the story of our lives in our hospital, then you go slow. You put your sodium at a very low concentration, and you obviously monitor the sodium. And it's recommended to at least just maintain an increment of 4 to 8 milli equivalent in 24 hours. So it's actually recommended that you do hourly sodium checks on the machine. And then if you feel like you've overshot, you can always use 5% dextrose to counteract your, if you've gone above what is recommended. So potential, just to summarize what I've just said, potential approach, according to the studies that use lowering your dialysis blood flow to slow intradialytic sodium transfer to the blood, and the total amount of sodium required to achieve the desired serum sodium in the total body water. That is the desired serum sodium increase in 24 hours, you times that by the total body water. Dilacylate to the blood flow gradient, and then you reduce your hemodialysis session to at least 120 to 150 minutes, and resulting in a flow rate that will be between 50 and 100. So obviously, I said that the hourly serum sodium checks are very important. And there are times where, for example, patient is hyperkalemic, they're cardiac failure, meaning they're hypervolemic, and they're hyponatremic. So you can do, you can dialyze them, might be necessary in patients who are hypervolemic just for volume control. Yes, hyponatremia and heart failure. So studies have shown that actually patients in heart failure, or with cardiac failure who happen to have hyponatremia, they tend to do worse than patients without hyponatremia and heart failure. How does that come about? Is that with heart failure, there's decreased cardiac output, obviously. Then there's decreased effective circulatory blood flow that gets to be sensed by the baroreceptors, and then that results in increase of the vasopressin. And we know the action of vasopressin is that it's going to increase the expression of V2 in the collecting duct, and by insertion of the aquaporin 2, and that is going to promote water reabsorption. And then you are hypovolemic and you are hyponatremic. And then the other mechanism is that with decreased cardiac output is going to be sent by the sympathetic nervous system, and that activating the angiotensin 2, because they're going to have a renal hypoperfusion. And we know that with rest activation, you're going to have renal vasoconstriction. And with renal vasoconstriction, you're going to promote proximally sodium and water reabsorption, and that delays distal delivery of sodium, and that's going to be sensed by the granular cells at the juxtaglabellar apparatus, and that's going to promote sodium and water reabsorption. So this is just how vasopressin is going to negatively affect the outcome of a heart failure patient with hyponatremia. As I've mentioned, acts via V1A and V1B and V2. So V1A, it causes vasoconstriction. That is going to increase the afterload, and that is going to cause left ventricular hypertrophy and remodeling. And if there's more water reabsorption, you're going to increase the preload, and unfortunately, going to have hyponatremia. Hyponatremia in critically ill patients. Hyponatremia is frequently finding in critical ill patients, and most of these patients are actually euvolemic, with SIDH being the most common cause, and often notice that pneumonia being the leading cause of this SIDH. And however, other causes they can also contribute. And then it has been found that patients who are hyponatremic in ICU, they tend to stay longer. They tend to be on a mechanical ventilation longer, and they tend to have a poorer outcome. This is just one of the studies that have they've done a study showing that hyponatremia in critical ill patients. In this patient, they said that there was 34%, and most of them, at least 58.9% of them, they were euvolemic, and the mean age were older, 60, and SIDH criteria was met in at least 36.25 of those patients, with pneumonia being the commonest cause, and they tend to have stayed longer in ICU compared to patients without hyponatremia. This is just a schematic representation of the study, that sepsis was the contributing factor, followed by pneumonia, and others were relatively more or less the same. It is the same study. They are proving that patients with normal serum sodium in ICU, they do better than those with hyponatremia. They tend to, the hyponatremic patient stays longer than the patient with normal hyponatremia. Here they were comparing parameters such as the number of patients with hyponatremia in ICU, the number of days they stayed, the number of days they spent off mechanical ventilation, and the number of days that this patient needed renal replacement therapy. And once more, they've proven that the hyponatremic patients were doing worse compared to the patients without hyponatremia. So increased mortality in elderly patients admitted with hyponatremia. This was a prospective cohort study. Once again, they've proven that elderly patients who present with hyponatremia, they stay longer in hospital, and their mortality rate increased by 17.4%. And there is increased risk of readmission at 3 months, at 6 months, and at 12 months. So if you were to compare an elderly patient who comes to hospital with hyponatremia with that one that comes to hospital with hyponatremia, the one that comes with hyponatremia do quite badly, regardless of where is it mild hyponatremia, moderate hyponatremia, or severe hyponatremia. The outcome, if you check, is that the older you are, the lower the sodium during your admission, the likelihood of you not doing well is very high. So this is to compare mortality during hospitalization with comparing mild hyponatremia, moderate hyponatremia, and severe during mild hyponatremia of about like 130. Mortality is still significant. I mean, it's approaching close to 20%, and moderate is approaching 30%, and when it's severe, it's even more. So I think the take-home message here is that hyponatremia in critically ill patients, it has worst outcome. In elderly, it has worst outcome. It has worst outcome, and it's associated with increased morbidity and mortality generally. And please be cautious when you replace the potassium. And if you are in renal, be gentle with your dialysis, short time, low blood speed, and the lowest achievable dialysate sodium of about 130 it is recommended. If you have access to consumables of HD, it might be a better mode. All right, thank you very much.
To say a few words maybe about